Thank you everyone for inviting me here to be able to talk about acute pancreatitis from treatment with BRAF inhibitors in Erdheim-Chester Disease patients. I'd like to thank Gaurav and Dr. Go for giving me this opportunity and for being my mentors. So to give some background that you guys all know, vemurafenib and dabrafenib, these are the two BRAF inhibitors that are available. Mechanism of action is that they selectively inhibit the mutated BRAF protein kinase with the V600E mutation, and in that process prevent tumor cell growth. For Erdheim-Chester disease patients, 50 to 60% of them have the BRAF V600E mutation and are able to be treated with the BRAF inhibitors. So for vemurafenib, it was approved in 2017 by the FDA, and then dabrafenib has no FDA approval yet, but there have been case reports showing its efficacy in treating BRAF V600E ECD patients. So as BRAF inhibitor therapy becomes the cornerstone in treating V600E ECD patients, one important thing is understanding the adverse effect profile, since a lot of patients who end up taking BRAF inhibitor therapy fall off of treatment because of dermatologic side effects or because of constitutional symptoms. The adverse effect profile so far among the BRAF inhibitors is best known through the melanoma treated patients. There's many studies showing it, and the most common ones are for dermatologic conditions are photosensitivity, rash, hyperkeratosis, skin papillomas. Constitutional symptoms include fatigue, headaches, arthralgias. For Erdheim-Chester disease patients, really our data comes from the VE basket trial study that was done, which the most common side effects from vemurafenib therapy was arthralgias, rash, fatigue, and skin papillomas. So pancreatitis is a very rare side effect from BRAF inhibitor therapy, but it's one that has been documented in the literature. From a literature search that we did, we saw that among the metastatic melanoma patients, the frequency of pancreatitis from vemurafenib was very rare, 0.2%. This was based on 3 clinical trials. 2 had used vemurafenib 19-20 milligrams per day, and then the other study had 2 cohorts, one that was 240 milligrams dose escalated up to 1120, and then another cohort that was 19-20 milligrams per day. Among other hematologic malignancies, for hairy cell leukemia that was refractory to treatment and had a BRAF mutation, there was a study done by Tiaki et al. In the New England Journal of Medicine, which showed 2 cohorts totaling 54 patients, where 3 developed acute pancreatitis from vemurafenib therapy, and that was 19-20 milligrams per day. And what was interesting is that they had 2 cohorts. One was an Italian cohort of 28 patients, I believe, and then the other was a US cohort of 26 patients. And it was only the Italian cohort that had developed the pancreatitis side effect. So maybe it's because the Italians drink more alcohol, not really sure. So for dabrafenib, the data here is much more limited in terms of pancreatitis. Basically, there has been post-marketing studies that have shown dabrafenib causing pancreatitis, but other than that, the only clinical trial that I saw was one that used dabrafenib and trametinib as dual therapy, and there was just 1 out of 125 patients who had developed pancreatitis, and their dosages were 300 milligrams per day for dabrafenib and 2 milligrams per day for trametinib. So among the literature for ECD patients, we really just have the VE basket trial and then the LOVE trial with the 54 patients, and there was no report of acute pancreatitis that was developed in those patients. So our cohort at Mayo, we did a retrospective study, and we had looked at from 1998 to 2018, and then basically to utilize the diagnosis of pancreatitis, we had the criteria from the 2012 revised Atlanta criteria, which basically requires 2 out of 3 criteria. The first is you have to have a lipase that's 3 times above the upper limit of normal. Number 2 is severe abdominal pain that's characteristic of pancreatitis, so it radiates to the back, or you have nausea, vomiting, postprandial issues. And then number 3 is radiologic findings confirming acute pancreatitis. So you just need 2 out of 3. And then we also graded the severity of the pancreatitis using the CT-CAE criteria, which is, I'll talk about that in the next slide. So for our table, to just describe our cohort, we had 89 patients within our cohort. 44 were tested for the BRAF V600E mutation, and then 25 of those 44 were positive, which puts us in the 57% range. And then we had, among those 25 who were positive, 21 were treated with the BRAF inhibitor. Median age was 57 years old, 57% were male, and then the site of organ involvement, the most common was bone, followed by CNS, and then kidney. So among the 21 who were treated with the BRAF inhibitors, we had 18 who were treated with vemurafenib, 2 with the BRAF-inhib, and then 1 with dual therapy from the get-go. And then among those 21, we had 5 patients who were treated actually with a second BRAF inhibitor. And then there were 2 with vemurafenib, 2 with the BRAF-inhib, and 1 with the BRAF-inhib trametinib. And then adverse effects that we saw most commonly within our cohort study were dermatologic findings, which included skin papillomas, photosensitivity, rash, fatigue, and then 3 with acute pancreatitis. So this is the most important slide, which is our results showing the cohort of patients with pancreatitis. So let's see. Okay. So for the first patient, she was a 33-year-old female and had a prior therapy of methotrexate and infliximab. Her initial BRAF inhibitor that we used was vemurafenib 960, and she had progressed on disease with the methotrexate and infliximab. After starting the vemurafenib, for 4 days later, she suddenly developed severe abdominal pain, radiated to the back, worsened with postprandial meals, and then had an elevated lipase in the 700s. Her CT-CAE grade severity would then be 3. So 3 means that they had either severe abdominal pain that required medical intervention, and then grade 2 means it's just you have to have elevated lipase or a radiologic finding. So she had grade 3. She had stopped the vemurafenib therapy, and then once stopping it, her lipase resolved, abdominal pain went away. And then in the interim, when she was off of the BRAF therapy, she went back on methotrexate and infliximab. Unfortunately, she had progressed on those 2, and then was later decided to restart with dabrafenib and trametinib, and actually had partial response both radiologically and clinically. And then since last known follow-up was 12 months with no recurrence of pancreatitis. Our second patient was a 58-year-old gentleman who was on prednisone, methotrexate, and infliximab, and would start on vemurafenib of 1920. He had developed pancreatitis 28 days later, was stopped, and actually was put back on 1440 milligrams, but then had a recurrent episode of pancreatitis. So then he went off of it completely, and then actually didn't start any interim therapy when he was off of the vemurafenib, but later had progression of disease where the ECD affected his cardiovascular region. So then he was decided to be restarted on 960, and he actually did okay, and has since he had a partial and clinical and radiologic response. And he's had 20 months of follow-up with no recurrence of pancreatitis. And then our third patient was a 54-year-old gentleman who was initially on prednisone, methotrexate, progressed on disease, started on dabrafenib therapy, and then 1 day later had a lipase of 14,000 and also severe abdominal pain as well. And then was stopped, put on anakinra, but then progressed on anakinra, and then later was retrialed on vemurafenib, initially on 240, just to be safe, but he was progressing on 240, so they slowly went up to 480, then 720, and then he was fine after that. And he's been doing fine for 38 months. So just to kind of recap, so after discontinuing the initial BRAF inhibitor therapy, all of our patients had clinical and radiologic progression of disease. After restarting the second BRAF inhibitor therapy, all our patients ultimately had clinical and radiologic response to therapy. And then the time to restarting the second BRAF inhibitor for patient 1, 2, and 3 was respectively 32, 27, and 5 days. So medication-induced pancreatitis is pretty rare. It's less than 5%. The mechanism overall is unknown. There's a few hypotheses out there that it could be dose-related. It could be due to immune reaction. Could be due to ischemia too, if somehow the blood supply is affected. But overall, the mechanism just is not known. Once the medication is stopped and then the pancreatitis reverses itself, the prognosis is very good. So we think that our patients likely had pancreatitis due to the BRAF inhibitor therapy based on the exposure, the timeline, and then the onset of their acute pancreatitis, and then their immediate resolution of symptoms from both a subjective and also objective perspective, where their lipase came back to normal after discontinuing BRAF therapy. The limitation, of course, is that our study is a retrospective study, so there's always possibility that there could be confounders, and you can't really prove a causal factor. So overall, key points: as BRAF inhibitor therapy continues to become a cornerstone of therapy, it's important that we as hematologists, clinicians, know what the adverse effects are out there. Especially pancreatitis can be a very scary event for patients. Having that sudden abdominal pain can make them very reluctant to restart BRAF inhibitor therapy. So another thing that we had noted was that among the hematologic malignancies, so with the hairy cell leukemia patients, the frequency of pancreatitis from BRAF inhibitor therapy in ECD and hairy cell leukemia was higher than in the melanoma patients. Mechanism is unclear, and that's something that could be further investigated. And then the third point is that even though patients develop pancreatitis to BRAF inhibitor therapy, there is the possibility that you could restart them on a lower dose, or you can try switching them to this other BRAF inhibitor therapy. So again, thank you all for giving me this opportunity to talk, and please let me know what questions you have.
Yeah, very interesting, very insightful. One of my questions is, I believe you can get at least pancreatic pathology as a result of some of these other therapies. Methotrexate, I'm less sure about Remicade, but I think it's been observed with that as well. So do you have any insight into pancreatic disease from the BRAF inhibitors compared to the other therapies?
Great question. So there is a list of drugs that can cause pancreatitis, and there has been a classification out there where it's based on whether or not the patient has been rechallenged with that drug. So it's like if so, then that's a class 1 drug-induced pancreatitis medication. If they've never been rechallenged and it's just case reports in the literature, then it's either class 2 or class 3 based off of that. So I think for methotrexate and infliximab, there have been case reports out there, but it's like an association. It's not a causal effect, and I would think that if that was an issue, then they would have had the pancreatitis when they were on therapy, not when they were off, and then switched to the BRAF inhibitor.
I don't know if you looked at that, but I think all the kinase inhibitors cause pancreatitis, not just this. I mean, all the ones we use for CML, and the ones we use to treat kidney cancer, I suspect the ones for thyroid cancer as well. So it may be just a class effect, and they all have the same way. You know, either they have an elevation of the lipase or they have the full-blown syndrome, you stop, the prognosis is good, you can re-challenge them.
Right.
So,
Okay.
Right, I forgot all the 3 cases. Were they all Italians or not?
For our patients, they were all American, but for
But it's, the key thing, I guess, at least, is, we never talk about pancreatitis while treating other cancers with the BRAF inhibitor. Other kinase inhibitors is out there, but for some reason it was very interesting, and sort of the same percentage in the cell leukemia cohort, which was like, if you just look at the Italian cohort, it's the same, like 14-15% pancreatitis. So that was kind of another interesting thing. But certainly, you can re-challenge in this case, which according to what you had mentioned about, evidence level, I may make it level 2, I'm guessing, because you have re-challenged all of these patients and they did okay.
any other questions?
Did you notice in any of these, was there any commonality between the 3 patients that you were able to, identify?
Yeah, great question. There was nothing that we could find when we were trying to find commonalities.
They all had it within the first month.
Sorry.
They all had the pancreatitis within the first month.
Yes, within, I guess that's a
Yeah.
commonality, yeah.
Yeah.
Well, that was gonna be my question, is when, I did remember when they happened, because we run some large CML trials, and from that, the only thing I would say is I think we should caution patients on alcohol, check a fasting lipid panel, because we found a few of those cases. We even in 3 of our cases, they had a cult, these are in CML patients, either getting nilotinib or dasatinib, they had a cult cystic fibrosis. So it does appear that other risks for pancreatitis, may be, a cause. So just to caution patients on alcohol intake or something like that might be.
Yeah,
Thank you.
we had, after the LOVE study, we had 2 patients, at least 2 patients. One had a very mild pancreatitis, and the other one had more full-blown pancreatitis, first with VEM and then with DABRA. So
Okay.
then we had to put him on a MEK inhibitor afterwards. So it's probably more frequent than what we previously thought. So definitely.
Thank you.